Hello, and welcome to From the EBPL Archives, Encore presentations from the East Brunswick Public Library. I am your host, Melissa Hosick. This event was presented as part of our Just for the Health of It initiative. Just for the Health of It is a proprietary health literacy program developed by the East Brunswick Public Library to promote health literacy in Middlesex County. To learn more, visit justforthehealthofit.org. Now, enjoy the program.
Welcome, and thank you for joining us this afternoon for today's Lunch and Learn with the Doctors on Sleep Disorders. My name is Kathy Churn, and I am a consumer health librarian at East Brunswick Public Library. Today's program is brought to you by St. Peter's University Hospital and the library's Just for the Health initiative to promote community health and wellness. Our speakers today are Dr. Samuel Nee, Pediatric Sleep Specialist and Chief of Pediatric Sleep Medicine at the Children's Hospital at St. Peter's University Hospital, and Dr. Ashkan El-Shanawi, Pulmonologist and Medical Director of the Center for Sleep and Breathing Disorders at St. Peter's University Hospital. Please be aware that this talk is being recorded. Please keep your microphones muted and your webcams off. The recording will be available at ebpl.org/YouTube. If you have any questions, please type them into the chat box. Our speakers will answer questions at the end of the talk, and our speakers will not be able to offer medical advice to attendees during this program. And without further ado, I'll turn things over to our first speaker, Dr. Nee.
Thank you, Kathy. Happy to be here speaking at the library today. When I told my son, who's 4 years old, that I'll be speaking at the library today, he asked me if there's going to be ghosts there and are the Ghostbusters going to be at the library. So I said to him, well, no, the Ghostbusters won't be there, and you're probably watching too much TV and need to go to the library. So hopefully we'll be able to get back to the library soon. So I'm going to be talking about pediatric sleep problems. So this is really going to be relevant to people out there that have, young children or grandchildren. I have nothing to disclose. So a lot of people come to me for a variety of pediatric sleep problems. Today's talk, we're going to be addressing behavioral insomnia of childhood and pediatric sleep apnea. I'm not going to get into other pediatric sleep problems, but people come to see me for all different sleep disorders. As you can see over here on this slide, I see patients that have other issues such as restless leg syndrome, kids that come to me with night terrors, nightmares, and narcolepsy. So we see a wide variety of sleep problems here at the Center for Sleep and Breathing Disorders. So the first part of the talk, though, we're going to talk about behavioral insomnia of childhood, and then we'll talk about obstructive sleep apnea after. So a lot of people, when they have kids with sleep problems, they come and ask me, how much sleep does my child need? It's a very good question, and the answer is it really depends, right? It depends on how old your child is. So this is a nice chart that was put out by the American Academy of Pediatrics that really goes through the average amount of sleep that's required per age group. As you could see, the younger children require more sleep, and they also include naps. This is basically, a range of how much sleep is required per age over a 24-hour period. You can see that naps tend to fade out by school age. So it's important to, always reference this, chart when dealing with kids with sleep problems. Now, certainly if your child is getting an appropriate amount of sleep, but is having symptoms that are suggestive of a sleep disorder, that should be looked at as well. So it's not just an issue of quantity of sleep, but it's also, a matter of quality as well. But this is a very nice table, and something that you could look over, and you could look it up on the American Academy of Sleep Medicine as well as the American Academy of Pediatrics. So let's talk a little bit about behavioral insomnia of childhood, right? This is a very common problem. Roughly 20 to 30% of children suffer from insomnia at some point. And really, what is insomnia? Well, it's trouble falling asleep. It's trouble staying asleep. And in kids, it's due to poor behaviors that the child has become accustomed to. You can see here a kid that's probably having trouble falling asleep because he's hanging out and playing on his cell phone late at night. So sleep behavioral insomnia comes in two different flavors. The first flavor is sleep onset association, right? So this is where an infant or a child links falling asleep to an external stimulus. You can see a picture of a woman rocking her baby. Now, it's not considered insomnia if a child is under 6 months of age. So, under 6 months of age, we're not calling this a sleep problem. So once 6 months hits, then you could consider it a pediatric sleep problem. And of course, in order to go back to sleep in the middle of the night, the child will require that same stimulus, in this case, being rocked or held to go back to sleep. Now, I, always like to, tell families that when when they have a new baby, try to get the child to fall asleep without trying to rock them to sleep or really, hold them too much. It's good to, get them used to sleeping in their crib and, maybe patting them to sleep instead. So a lot of kids that are rocked to sleep, they'll require this to go back to sleep if they wake up in the middle of the night. The second flavor of pediatric behavioral insomnia is limit setting, right? So these are kids that protest going to bed, right? They make unreasonable demands before going to bed. Daddy, read me one more story. I want another glass of milk. And the way to, really deal with limit setting, behavioral insomnia is setting, firm limits, right? So having just, one story, one book, one song, and really, making sure that you establish firm limits. So, the mainstay of treating behavioral insomnia is, behavioral modification. So any pediatric sleep disorder, we start off with establishing a positive bedtime routine. So, every day, make sure you do something that's relaxing before going to bed, maybe giving some milk, taking a bath, reading a book, singing a song, whatever you do, make sure that, it's something relaxing, not overstimulating, and try to keep consistency. Now, in dealing with, behavioral insomnia, the approach that we take to treating it really depends on the type of, behavioral insomnia. If it's a young child, right, that is, being rocked to sleep, we recommend methods of extinction. So, one would be to, basically put the child to sleep in their crib and let them essentially self-soothe. Now, this is very difficult for parents to do. So some parents might try to do a more graduated method of extinction where they put the child to sleep in the bed and, we'll check on the child periodically throughout the night, initially starting off with short intervals and then increasing the intervals until the child is able to, self-soothe. For older children, for toddlers, doing these methods of extinction are difficult to do since older kids are able to get up and, leave the bedroom. So for older children, we like to do positive reward systems. So this might be something like a bedtime pass, where you give the child a few bedtime passes, and if they want to, leave the room, they can, but essentially they have to pay to leave the room. They have to give you a pass. And if they wake up in the morning with those passes still in hand, they haven't used them, then they can redeem them for something small like M&Ms or stickers. It's important to switch it up once in a while to, just keep things interesting and so the child doesn't get bored. But that's a type of positive reward routine that we use with older children. Now, some kids have trouble falling asleep because they might be going to bed, at a time that doesn't coincide with their body's internal clock. So, you might see, or I might see a 10-year-old in clinic that's going to bed at 7 p.m. And that might be, too early for that kid. And the parent says, it takes my child an hour or two to fall asleep. So then you might want to move their bedtime back to a later time. And that's called bedtime fading. So you move their bedtime back to a later time and then gradually shift it forward until you hit that sweet spot that really syncs up with that child's internal clock. So you might have to move back bedtime and delay bedtime if that seems to be the issue there. So really, our approach to behavioral insomnia is one of doing some behavioral modifications. And again, it really depends on the type of behavioral insomnia that's present. So we do a lot of different strategies, and we tailor the treatment towards that type of insomnia. Now, a lot of parents will ask me, do medications play a role, right? So there's a lot of medications out there that people might try over the counter to treat their children's sleep problems, right? So you guys might have heard of melatonin, Benadryl, some prescription sleep medicine. So I'm going to address those medications. So one of the more common medications used in treating, sleep problems is melatonin. So what is melatonin, right? Melatonin is a hormone that's secreted by your body. It's a natural substance that is secreted by your body about 2 hours before your habitual bedtime. Now, when lights are dim, that's when melatonin is secreted. So this is something that's made naturally by your body, but yes, you could buy it, over the counter. It's not considered a prescription medication, right? This is a supplement. It's kind of like a vitamin. So it's not really regulated as much by the FDA. So one batch of melatonin that you get from Rite Aid might be different than the melatonin that you get from CVS. So that's something to keep in mind. And when looking at the studies on melatonin in kids, there's really a very limited amount of literature on using melatonin to treat insomnia. The literature out there really doesn't show much of a benefit of using melatonin to treat behavioral insomnia. There has been shown some benefit in kids that have some neurodevelopmental issues, such as autism, and those kids might benefit from melatonin, but we do see a lot of children that have tried melatonin that was prescribed to them by their pediatrician, and eventually they built up a tolerance to it and it became ineffective. So really, at this point, I'm not recommending using melatonin for treating behavioral insomnia. I believe that behavioral modification strategies work a lot better than melatonin. I don't think melatonin is dangerous, right? The side effect profile is pretty benign. We don't really have studies looking at the long-term side effects of melatonin, but it seems to be relatively safe. But keep in mind that, melatonin that you get at one place could be different than another place. And the dosage that's listed on it might not be entirely accurate, since it is not heavily regulated by the FDA. So at this point, I'm not recommending using melatonin for behavioral insomnia. Another medication that people might try giving their kids is diphenhydramine, right? Also known as Benadryl. Now, Benadryl can make you tired, but it also can make you wired. And younger kids, it sometimes has this opposite reaction where the kid even becomes more hyper after getting Benadryl. So they're really, again, like with melatonin, there's very limited studies looking at whether or not Benadryl can help kids fall asleep. But the studies that are out there really doesn't show much of a benefit as well. So again, I'm not recommending using Benadryl for behavioral sleep problems. Prescription sleep aids. So Dr. El-Shanawi will talk more about insomnia of adults. In kids, right, we don't use any prescription sleep aids such as Ambien, Sonata, all the different prescription sleep aids. So these are not approved in pediatrics. So really, the sense that I hope you're getting is that the main way of treating this is working on treating behaviors and dealing with sleep hygiene, right, if sleep hygiene is an issue. So I'm going to talk to you a little bit more about some basic, sleep hygiene that I think and everyone can implement with their children and for themselves as well. So again, as I mentioned before, it's important to have a good bedtime routine, right? Every sleep problem, the root of it, we should always go back to having a consistent and relaxing bedtime routine in order to deal with the issue. So again, reading a book, singing a song, something that's not overly stimulating. Making sure you keep a consistent sleep schedule is very important, right? So make sure that you get the same bedtime and same wake time on weekdays and weekends. Make sure you set a bedtime, right, that is early enough for you to get the required amount of sleep. So, that brings me back to that chart of how much sleep a child needs. So, make sure your child is getting the appropriate amount of sleep for their age group. Don't go to bed if you're not sleepy, right? If you can't fall asleep quickly within like 20, 30 minutes, get up, get out of bed, do something boring, something, not too stimulating. So read a book, or, I tell kids maybe to fold some laundry, the parents always get a kick out of that, right? Something that is boring. And then once they feel more tired, then to get up and to go back into bed. The bedroom really should only be used for sleep. You can see here a picture of a kid watching TV in bed. And I know now during the pandemic, kids are hanging out in their bedrooms more. I get that. But if they are hanging out in their bedrooms, if they're doing work there, try not to do the work on their beds, really, work at their desks. So really use the bedroom really only for sleep. And make sure your bedroom is quiet, relaxing, and at a cool temperature. This is important for our teenagers, right? To limit exposure to bright lights in the evening and try to turn off electronics late at night, right? So our older kids, they're on their electronic devices, all day and all night right now. And, it's very important to try to turn off the electronics at least 30 minutes, preferably an hour before they go to bed, because the blue light from our electronic devices, right, tricks the body essentially into feeling more awake. It could also block the secretion of melatonin, again, a natural hormone that makes you feel tired. So that this is also very important, especially for our teenagers. So when is, a sleep problem not just the behavioral issue, right? When is it a medical issue? So we're going to talk about now pediatric obstructive sleep apnea. So this is a very common, medical sleep problem that I see in kids. One of the more common problems that I see in sleep clinic. So these is going to, give you a sense of when your child might have something more than a behavioral issue. So what is pediatric sleep apnea? So this is a disorder of breathing, right? That's characterized by an obstruction of the airway that disrupts normal ventilation during sleep, right? So the airway gets blocked during the night, it collapses, and this can cause oxygen to drop. And this could lead to your brain waking up several times throughout the night. And this could lead to consequences, which we'll get into. So when do we see pediatric sleep apnea? So I see it in kids of all ages, but really the peak ages is between 2 and 8. And roughly 1 to 5% of children have pediatric obstructive sleep apnea. So this is a relatively common sleep problem. What causes sleep apnea? So anything that can cause a collapsing or obstruction of the upper airway. In kids, this is due to typically big tonsils and big adenoids. So this is a picture of a normal airway, and you can see it here over on the left. This is airflow through the nasal passages down into the trachea and down into the lungs, right? This is a normal airway with normal adenoids, which are on the back of the nose, and normal sized tonsils. You can see here in the picture of the right, this is a child that has enlarged adenoids and enlarged tonsils. So you can see here that the airflow is not as linear, right? This is airflow that is obstructed, and this is a child that's more prone to sleep apnea. So other conditions that can lead to obstructive sleep apnea, so obesity, right? That those children have extra fatty depositions in their throats that can cause obstruction of their airways. Kids with syndromes, right, might be more prone to sleep apnea. The picture of a child on the left, you can see a kid with Down syndrome. Kids with Down syndrome, they have more floppier airways at baseline. They have enlarged tongues, right? So that could lead towards obstructive sleep apnea as well, or other kids with neuromuscular conditions. The picture of a child on the right is someone that has Pierre-Robin syndrome. So this is a kid with a very small recessed jaw and a corresponding small airway. Other conditions that are associated with pediatric obstructive sleep apnea are asthma and allergies, other inflammatory conditions. This could cause inflammation of the airways. It could also increase the tonsils and the sides of the adenoids. So what are the consequences, right, of obstructive sleep apnea? So there are several. Kids that are getting poor quality of sleep and have sleep apnea, they look like kids that have, ADHD. A lot of kids that come to see me were previously diagnosed with ADHD, and in fact, they have a sleep problem and not ADHD. So kids that aren't sleeping well, they are hyperactive, they're inattentive, they have difficulty focusing in school, and they might have behavioral issues, right? So kids with sleep problems are a little bit different than adults. Dr. Arsenali will talk to you about what sleep apnea looks like in adults. Some of our older kids, they might be sleepy, but typically they're the other the other side of the spectrum, and they're more hyperactive. If sleep apnea goes on for a long time in kids, right, it can lead to issues with the heart, like high blood pressure. So throughout the night, when your brain is waking up from sleep apnea, your blood pressure also shoots up as well. So if this is going on many times throughout the night over years, this could lead to problems with blood pressure. It could also lead to issues with your metabolism, your ability to regulate blood sugar, and it could also affect your cholesterol as well in kids. So obviously, if sleep apnea is present, it's important that we address it, and we address it early. So what are some of the symptoms of sleep apnea, right? So this is important to know. Is this, this will lead you to believe that, you're dealing with a medical problem here. So children that snore, right? Kids that snore, their tongues, they go back to the back of their throat and they obstruct their airway at night. Gasping for air, trouble breathing at night. So kids that have sleep apnea, their stomachs sometimes go in while their chests go out and vice versa. So that might lead you to believe that they have obstructive sleep apnea. If they have trouble falling asleep and staying asleep as well, and they have snoring and some other issues, that could also be sleep apnea. So it might not be just a behavioral issue. Kids that have sleep apnea, they're restless sleepers. They toss and turn a lot. They might mouth breathe, right? Kids with big adenoids, which are in the back of the nose, in order to compensate, they're going to keep their mouths open, and they might sleep with their head and necks extended. You might even witness them having pauses in breathing, which is very suggestive of sleep apnea. Kids that have bedwetting at inappropriate ages, also a symptom of sleep apnea. So these are some of the nighttime symptoms. There's also daytime symptoms of sleep apnea. And I mentioned those before. A lot of it is, kids that are having trouble focusing or they're hyperactive. The older kids might be sleepier. Some of them wake up with headaches, and they might have changes in their behavior and moods. So these are some of the daytime symptoms of sleep apnea. How do we diagnose sleep apnea in kids? So this is a little bit different than adults. In kids, the mainstay of diagnosing sleep apnea is by doing an in-laboratory sleep study, right? So a child will come in and sleep overnight. They'll be hooked up to a lot of different wires. We're monitoring their oxygen, monitoring their breathing at night. And what we're looking for is, pauses in breathing, and shallow breathing is what we see in sleep apnea, drops in oxygen. So this is how we diagnose sleep apnea. It's just a one night where they sleep overnight in our sleep lab, which kind of looks like a little hotel. And they go home, and after a week or two, we will get them the results and go over the results with them. I'm not going to get too much into the treatment of sleep apnea. It's really a very nuanced treatment for kids. I'm just going to briefly touch upon some of the different treatment modalities, but it really depends on how bad the sleep apnea is, how bad the symptoms are. That's how we tailor treatment. So if the sleep apnea is significant and there's tonsils and adenoids are obstructing the airway, we might send someone to an ear, nose, and throat doctor to see if they need surgery to take out their tonsils and adenoids. Other treatment options are medications, right? We use some medications that can help shrink tonsils and adenoids. If someone has asthma and allergies, optimizing their management of their asthma and allergies can help as well. There's also orthodontic procedures that can help improve nasal breathing and treat sleep apnea. And there's also breathing machines such as CPAP, which we don't use that often in children, but it is an adjunct therapy, and it is an option for kids that do have significant sleep apnea that might not be candidates for surgery, or for residual sleep apnea in kids that have already had their tonsils and adenoids removed. So that's a little bit about pediatric sleep disorders. I'm going to allow my colleague, Dr. El-Shanawi, to address the adult sleep disorders.
Okay. Hi, can you hear me, Sam?
Yes, I can hear you.
Okay. Well, thank you so much. Dr. D, that was actually really, really good. I know you very well, but I was impressed even more. So you covered a lot of material, which actually makes my job a lot easier because I don't have to go in detail with some of the stuff you covered already, because obviously there's some overlap. I'm really glad you mentioned the Benadryl and emphasize that it's probably not a good idea to give your kids Benadryl to sleep. And I say that because I learned it the hard way personally. And when just a little vignette, I didn't plan this, but when my son was 2 years old, I was traveling alone with him on an international flight, 11 hours with a 2-year-old. I mean, that's ridiculous, right? It's a setup for failure. And then he was just so erratic. He couldn't sleep. He was jumping up and down. I had to carry him. I said, I'm giving him Benadryl. I'm done. And I've never done it before. I gave him Benadryl and he bounced off the wall even more so for the entire flight. I wanted to shoot myself.
Right.
there was a passing moment where I literally thought, you know, a plane crash is not that bad of a thing right now. I swear to you. So don't give your kids Benadryl. That's the moral of the story.
I concur.
So I'm sorry, you brought me back to that PTSD moment. Okay. So let me share my screen. I wanted to thank the folks at East Brunswick Library for inviting us to share some of our hopefully expertise with you guys about sleep disorders. And I want to say I'm a proud patron of the East Brunswick Public Library. I live a few blocks away, and I really, really miss being in there physically. And I really pray that we can reunite physically again one day. Okay. All right, very good. Let me share my screen. All right, so I'm going to be talking about sleep apnea and insomnia in adults. So the sleep apnea is actually very similar to what Dr. Nee talked about, so I won't go into too much detail about what he spoke about because there's a lot of overlap, but there are very distinct differences too. And insomnia also very different in terms of how we approach it, their symptoms and how we treat it, okay? So that's what I'm going to try to focus on, mostly adults. Okay, so to start with the definition of sleep apnea, it means that you literally stop breathing for at least 10 seconds at a time, and it has to happen at least 5 times an hour during sleep, okay? So that's what we look at when we do sleep studies. We look to see if you stop breathing 5 times an hour or more, and there's people who stop breathing a lot more than that. And I'm sure, you know, Dr. Nee could tell you stories how we see people who stop breathing 60, 80, 100 times an hour. It's actually possible to stop breathing that often. All right, this one. So the signs and symptoms of sleep apnea, so that if you have some of these, you may want to consider maybe getting a screening or a diagnostic test, but we'll talk about that next. So some of the symptoms we see with sleep apnea in adults is snoring, witness apneas. That means your bed partner may actually witness you stop breathing. So your stomach, your chest is moving, and all of a sudden it's not. And I've had people videotape their partner, bring it to the office. I've had people time their partners stopping breathing, and they tell me, oh my God, it's 50 seconds, 60 seconds. One wife said, he stopped breathing for a good 2 minutes. And I'm thinking, how are you watching this and not waking him up? And I said, 2 minutes is too long. So yeah, if you see your partner stop breathing, shake them, have them turn over, because yeah, it could be dangerous if it goes that long. So interrupted sleep, like restless, you wake up and you find your bed, your sheets are kind of like almost like a tornado hit it. Multiple awakenings to visit the bathroom. I have so many patients who are so used to getting up 2, 3, 4 times a night to go to the bathroom, and they think that's normal. And they could be in their 40s or 50s, and I tell them that's not normal to go to the bathroom that often when you don't have a urologic problem. And usually that's because you wake up from the sleep apnea, and then all of us know that if we wake up in the middle of the night, we have an urge to go to the bathroom. So they feel like the urge is waking them up, but it's actually not. And we prove that once we treat their sleep apnea, and then they tell me, I don't get up in the middle of the night anymore to go to the bathroom, or I may just go once. So they see a big difference. Daytime sleepiness, and I have that in bold for a reason, but we'll visit that in another slide. But if you feel fatigued and tired and always feeling like you could take a nap easily during the day. And we have a little questionnaire that we ask people to kind of quantify how sleepy they are. And I'll show that to you soon. People report morning headaches or dry mouth. They have a hard time concentrating and focusing, whether it's at school, like Dr. Nee mentioned, or at their workplace, and labile mood. So they're very irritable, they're easily angered. Their partners will tell me they like just kind of go from 0 to 100 really quickly. So that's what we're talking about when we see signs and symptoms, when we talk about signs and symptoms of sleep apnea. So next, what does sleep apnea actually do to your heart and brain? And I try, it does a lot more than what I have listed here, but I'm really trying to simplify it right now and give you the most common things. And if there are questions about anything else not in the slide, please ask us. But the main things that we see over and over again, unfortunately, is high blood pressure. There's a strong association between sleep apnea, untreated sleep apnea, and high blood pressure. And also we see irregular heart rhythm. So some of you may be familiar with the terms as atrial fibrillation or SVT or PVCs. You know, it's if you know the names, that means your doctor at one point told you you have that. And unfortunately, because when sleep apnea happens, adrenaline is released into your bloodstream. Every time you have a long apnea, adrenaline goes into your system, and that speeds up your heart rate and your blood pressure and can cause you to go into an irregular heart rhythm, which is potentially dangerous and can cause strokes, which I listed at the bottom. It also can cause a very fast or really slow heart rate. So even though we've been focusing on how it goes faster, I've seen people go very slow, like in the 30s or 20s heart rate, which is dangerous in some circumstances. And some of these people not only need treatment for their sleep apnea, but need a pacemaker placed. And some of you may be familiar with that as well. Alrighty, let's move on. Okay, so this is the Epworth Sleepiness Scale that I was talking about. This is what we use in the office to kind of try to quantify how sleepy you are. And if you guys can take a moment and grab a pen and paper, so we're going to try to make it a little interactive instead of you just listening to me. So this is what I would do in the office. So pretend that I'm seeing you in the office, and this is the questions I'm going to ask you. And I want you to write down on a piece of paper, unless you have a really good memory and can just remember the numbers. And you're going to rate it from 0 to 3 of your chance of dozing in any of those circumstances. Okay, 0 means there's no way you would doze off. 1, there's a slight chance. 2, there's a really good chance. And 3, oh my God, I'll pass out in that circumstance. Okay, so I want you to rate each circumstance, okay, with 0 to 3, anywhere. So sitting and reading, what is your chance of dozing off? Write down your number. Watching TV, what is the chance of you dozing off? Sitting inactive in a public place, like a theater watching a movie or a meeting, or on a Zoom call, for example. As a passenger in a car for an hour without a break. Okay, so not as a driver, because if you're sleepy as a driver, that's a whole nother problem, but as a passenger. Lying down to rest in the afternoon when circumstances permit, would you possibly doze off? Sitting and talking to someone, just one-on-one, would you sleep in that circumstance? Sitting quietly after lunch without alcohol intake. In a car while stopped for a few minutes in traffic, and that's as a driver. All right, did everybody put their scores in? I'll give you like 30 more seconds, okay? And then we're going to tally up all the numbers for these 8 questions. Okay, so the least you can have is 0. If you put 0 for all of them, the highest number you can get is 24. So anything higher than 10 means you're pretty sleepy, and that doesn't mean you have sleep apnea, but it means that either you have insufficient sleep, you're not getting enough sleep, or your quality of sleep is poor, or you may have sleep apnea. So it's just a marker of it. It doesn't diagnose you with sleep apnea. So hopefully that was helpful to some of you, and you could give this to your friends and family for fun, because we're obviously bored during the pandemic. All right, here we go. Next slide. Okay. Don't leave, don't put away your pencil and paper, because we have one more questionnaire for you. And I promise this is the last one. So this is another very important questionnaire that we put in our offices and in our sleep centers. And this one is actually even more valid and helpful than the one I just gave you, because the other one was just really quantifying how sleepy you are. This questionnaire, and I'm going to walk you through it, really tells us, your physicians or caregivers, if you really have a good chance for having sleep apnea. So if you test positive on this, that buys you a sleep study, and your insurance would cover it most likely, but we'll talk about that in a minute. All right, so let's answer these questions. And again, give yourself 1 point if you answer any of these questions yes. Okay, so the first question, do you snore loudly, loud enough to be heard through closed doors, or your bed partner elbows you for snoring at night? If you do snore loudly, put a point for yourself there. 2, do you often feel tired, fatigued, or sleepy during the daytime, such as falling asleep during driving? If you do, put another point there. Has anyone observed you to stop breathing or choking or gasping during your sleep? Another point if it applies to you. Pressure, do you have or are being treated for high blood pressure? So even if your blood pressure is normal now because you're taking 1 medicine or 2 medicines or more, you still get a point for that. You just have to have a history of it, okay? Is your body mass index, and some of you may not know this answer, you'd have to kind of calculate it, and there's BMI calculators on, you could Google it, and you can literally put your height and your weight, and it will tell you what your BMI is. And if it's higher than 35, then that's in the obese category. And I hate that word, and I'm sorry, but that's the medical term for it. And it does put you at higher risk for sleep apnea. Age older than 50, just if you're older than 50, puts you at higher risk for sleep apnea. Your neck size, and again, a lot of people don't know their neck size. Men usually do because the shirt, the collar that they wear. So you know that size of the shirt, but women usually don't know, but they'd have to really measure with a measuring tape. So for men, if your shirt collar is 17 inches or larger, then you give yourself a point there. For women, it's 16 inches or larger. So again, obviously, if you don't have to measure right now, you could do it later. And last question is, are you a male? And if you're a male, you get a point just for being a guy. And I'm sorry to say that, but that puts you at higher risk for sleep apnea. Now, once you tallied up all your points there, if you score even three points, you're at a higher risk for sleep apnea. But the higher you score, 4, 5, 6, some of you will be 8 out of 8. That is very high risk for sleep apnea. And you should definitely speak to your doctor, maybe consult with a sleep specialist, but certainly not necessary. Just start speaking to your primary care doctor about your screening test, which is a very valid test, and say, do I need to have a sleep study? And discuss it with each other and decide together. All right, I'm leaving this busy slide. All right. How is sleep apnea diagnosed? And I'm not going to go into too much detail because Dr. Nee already went over it. And the first one, and as he told you, with children, they all get it done in the sleep center. For adults, we have an option to either send you to the sleep center, and there are certain reasons why I would send an adult patient to a sleep center rather than doing a home sleep study. So some of those reasons would include if you have a history of COPD, which is chronic obstructive pulmonary disease, like emphysema, for example. If you're on oxygen at home, if you have interstitial lung disease or scarring in your lungs, if you have congestive heart failure, if you ever had a stroke, those are the reasons I would send you to a sleep center and not choose a home sleep study, okay? Now, home sleep studies have become more and more popular even before the pandemic hit because they're convenient, they're relatively inexpensive, they're almost always covered by the insurance and approved and authorized by the insurance. And patients love them because they come pick up the device, they take it home, or we ship it to them, whatever they choose. And we have both options at St. Peter's Sleep Center. And the sleep study is done at home for 1 night, and the patient returns it, and the next day we download the data, and one of us interprets the data, and we contact you with the results and with a follow-up visit or a call and let you know what treatment options are available for you. Okay. Now, how is sleep apnea treated for adults? Okay, so CPAP or continuous positive airway pressure, I think a lot of you are familiar because you have a friend or a family relative or a neighbor who has CPAP. Involves wearing a mask over the nose or over the nose and mouth, and it delivers air pressure just to keep that back of the throat open enough to eliminate the snoring, eliminate the apneas, and improve your oxygen level throughout the night. And if that happens, remember, then you won't have the adrenaline release and you won't have the blood pressure surges and the heart rate surges. So it's all connected, it's cause and effect. The other option for sleep apnea, especially if you have mild or moderate sleep apnea, and that's defined as if you stop breathing anywhere between 5 to 29 times an hour, believe it or not, is considered mild to moderate. We can send you to a dentist who specializes in treatment of sleep apnea, and they can fit you for an appliance that goes usually on your lower jaw, pulls it out just a few millimeters while you're sleeping. You really don't feel much of a difference except the bite may be off, but that helps treat the sleep apnea. And I choose that as a second option, not as a first line. If someone tried CPAP and didn't tolerate it, or for some reason it wasn't covered, or for whatever reason, we go on to dental appliance. The convenience of that is that you have this little device, you could put it in your pocket, your purse, whatever, and you could travel with it. And it's so easy, you could just pop it in at night and take it out in the morning. There's also options for mouth throat surgery. I don't advise a lot of surgery in my adult patients. If I had a pediatric patient, definitely I see the outcomes are so much safer and certainly more effective than they are in adults. But I'm not going to list all the surgeries right now because there are actually so many surgeries that are done to treat sleep apnea. But I find a lot of them are not totally effective in the long term. So usually after 1 to 2 years, sometimes the tissue comes back, or the sleep apnea certainly comes back. I've seen that often. That's why I tend to not recommend it highly. Weight loss, if you do fit into that category where your body mass index is above 30 or 35, weight loss can certainly help you improve your sleep apnea. There are a new implanted device called Inspire, which is implanted under the skin, very similar to how a pacemaker is implanted. And the wire, though, the electrode actually goes into what's called your hypoglossal nerve, which controls your tongue, back of the throat, and it helps keep it open, stimulates it open while you're sleeping, and then you can actually turn it off when you wake up. And it's been pretty safe. It's been out there for at least 5 or 6 years, and ear, nose, and throat surgeons actually perform that procedure. So you would have to consult with one of them after you've seen perhaps a sleep specialist. Positional therapy just means the position you're in bed when you're sleeping. So we find some people, most people, their sleep apnea is worse when you're lying completely on your back, flat on your back. And so we tell people, if that's the case, especially if it's mild sleep apnea and it's on your back, we tell people, you know what, you could do away with CPAP. You could possibly sleep on your side, prop some pillows, body pillows, whatever you got to do to keep on your side. But unfortunately, long term, it's really not effective because people will end up just going right back onto their back. So I kind of use that as a temporary short term until I get them definitive treatment. Okay. All right. So a rough transition here from sleep apnea to insomnia, and just checking the time, make sure we're good. Okay. So I'll try to rush through this a little bit. So we have two kind of categories of insomnia in adults that I see. And I see a lot of patients with insomnia, and it's actually one of the more common reasons why I see patients with sleep disorders. So there's sleep onset and sleep maintenance. What that means is sleep onset is the person cannot initiate sleep. They're in bed, tossing and turning, looking at the clock, looking at their phone. They just cannot fall asleep for whatever reason. Sleep maintenance means you are able to fall asleep as soon as you hit the pillow, but then you wake up several times during the night for whatever reason. Some patients have both of the worst of the two worlds there. Okay. Some causes of of insomnia in adults include stress, and we have a little pandemic going on, and I have seen so many patients who are not only depressed, anxious about the pandemic. I think we all are at some level, not just you guys, it's affecting us as well. And it definitely does affect our sleep. And not only do we have sleep onset or sleep maintenance insomnia, that just the quality is so poor because some of us have nightmares, some of us are just stressed about this pandemic and when is it going to end. So even before the pandemic, though, the biggest reasons for insomnia in adults is depression and anxiety. So I always try to evaluate for that when I get a new patient with insomnia. Some patients, especially women, when they enter the years of menopause, their sleep just is completely rigged. And some patients, very, very fortunately, it doesn't affect them at all. Some individuals, some women, but a lot of women, once the estrogen levels decline during menopause, they'll notice their sleep, they can't sleep as long as they used to, whether it's hot flashes or even not, they're just not able to sleep. So we give them very specific guidelines. Travel for people, especially who do business, who travel across time zones in the country or even outside the country. It's really rough getting them to sleep well because every week is completely different. But we have measures to help those folks as well. Shift workers who work at night, just like our wonderful sleep technicians at our sleep center, they work nights, most of them, and it's really, really rough. I commend them for what they do, because I remember working at night when I was an intern, and it's a different lifestyle. And no matter how much sleep you try to get during the day, it doesn't feel quite right, because we were kind of designed to sleep at night and stay up during the day. So what they do is just pretty amazing, and to carry out their life during the day too, normally. Medications, I always look at the medications when people come to me with insomnia, because sometimes they're the culprit. So if someone is on a diuretic, which is a water pill that can wake them up in the middle of the night, and that might be why they're getting up 3-4 times a night. Sometimes it's simple as that. And I'll tell them, take it in the morning, not at night, and then problem solved. Okay, you don't need a sleep study, or you don't really need the medication. You just need to adjust your medications around. Decongestants, a lot of people are on decongestants without even knowing they're on decongestants. So for some of you who have allergies and take like Claritin D or Allegra D or Zyrtec D, the D part is the decongestant, and it's in there whether you like it or not, if you buy that one. So I always recommend to get the antihistamine without the decongestant, because decongestants are notorious for causing insomnia, and they last in your system for so long. So once you take it, especially at night, it's really rough to sleep that entire night. Caffeine, even though it's not a medication, a lot of us treat it as such. It's a drug of choice, and that definitely keeps you up and alert. But that's good during the day. I tell people to try to cut out all caffeine intake after 3 p.m. if possible, because it can last in your system for up to at least 10 hours. And so we don't want that intake in the evening for sure, because that will definitely not only wake you up because it's alerting, but it also acts as a diuretic and makes you go to the bathroom to urinate more often. So we don't need that at night. So keep those medications away from nighttime especially. Okay. Sorry, that was a mouthful, I know. Okay, so treatment for insomnia, very different, yet very similar to what Dr. Nee talked about. So sleep hygiene, I'm so happy he went into it in so much detail, so I'm not going to, and especially because we're probably running out of time. So when you guys play this back, when it's recorded on YouTube, you can obviously revisit his slides about the sleep hygiene, which were excellent. The next thing that I do, because sleep hygiene is the foundation, we always start with that. But statistically, sleep hygiene alone, if you only practice sleep hygiene, that's not enough to treat your insomnia. That's been proven over and over again, but it has to be one of the components of the treatment. The real treatment that has worked for most people with insomnia, especially if they stick with it, is cognitive behavioral therapy. And there's certain different components to that, and we go through it during our visits when we talk about insomnia. But just for one example, it's one of the components is called sleep restriction therapy. And I think Dr. Nee kind of touched upon that even with the children, because we want to limit the time you're in bed to the amount of time you think you're realistically going to sleep. So if you're sleeping from midnight, waking up at 5, and you're driving yourself crazy, I have people going to bed at 9, hoping they'll sleep before midnight, but they end up just tossing and turning for 3 hours, and it's very anxiety provoking. So I tell them, don't punish yourself, go to bed at midnight and get up at 5, and do it long enough until that whole stretch is filled with sleep. And then you can kind of come back and put your bedtime at 11:45. It's then 11:30, and you have to do it really slowly to train the brain to really prolong that sleep schedule. So we do that in detail in the office. I'm not going to go into too much detail now because it may not apply to everyone's listening right now, but there are different components to cognitive behavioral therapy, and it's proven over and over again that it works even much more than medications ever could. Okay, and it's safe because it doesn't require you popping a pill. Now, the last resort, and I think you see that as a common theme between pediatrics and adults, is it really is the last resort. I will prescribe, and I have prescribed medications, sleep aids many times, but only after, we've tried everything and it's really affecting the person's quality of life, their work, their school. Then I introduce the safest medications I can, and hopefully ones that are not habit forming, and they're not overly sedating, but just help the person ease into sleep. And I always tell them this is a short-term solution. I don't like to have sleep aids on for years. So that's a key thing that we tell everyone. Do I have, oh, no, I think that's it. Yay, I'm done with my part. And I think I'm gonna give it back to the East Brunswick Library folks to see if we have any questions from our audience. Thank you for listening.
Okay, great. Thank you. Dr. Al-Shanawi and Dr. Nee, thank you so much. So we're going to start with our Q&A now. We have time for just a couple questions. And so if you have any questions, type them into the chat box, please. And let me just see. Okay, so we have one comment and a question. So first, thanks for some great information. And question, can we learn anything useful by taking oxygen readings through the fingertip when waking up at night with respect to the risk of sleep apnea? Does O2 level bounce back too quickly when you wake up so that this is not useful? And is a heart rate of 90 beats per minute when waking up high enough to be an indication of sleep apnea?
You want me to take that, Sam?
Yeah, I'll let you take that one.
Okay, that's a really good question. And I've actually been asked that. So sometimes my patients will tell me, I don't think I have sleep apnea, because when I get up, I check my pulse ox, the finger probe, and it's normal. It's 92 and it's 94. And I tell them that's not really a valid indication because you are awake. And what you said about, does it bounce back very quickly? That's an excellent point. It really depends. If you have a very long apnea, meaning you stop breathing for a good minute, your oxygen decline may last a little longer. So if you get up gasping for air and you slap that quickly, you might catch it when it goes into the 80s. Below 90, we say, is, it's not normal. But you can't really rely on that. Sometimes we actually do oxygen, like as a pulmonologist, I do that test often in the patient's home, where I mail them an oximetry probe that monitors their oxygen the entire night. So they're not just doing random checks. And that data comes back to me, and I can then tell them your oxygen was low for 40 minutes that night, or for 20 minutes or whatever. And then what was the second part? I'm sorry.
The second part is a heart rate of 90 beats per minute when waking up high enough to be an indication of sleep apnea?
Yeah, not necessarily. However, it really will depend on what your resting wake heart rate is. So if you're sitting around, watching TV calm, and you check your heart rate and it's usually 60 or 70, then a heart rate of 90 during the night is actually abnormal, because when you sleep, for all of us, whether you have sleep apnea or not, your heart rate is supposed to actually go down. So if you have 70 during the day, your heart rate should be 60 or maybe even 50 when you're asleep. Again, when you're waking up and measuring it, you may have that fight or flight thing going on, and that might be the reason. But no, a 90, if your heart rate was 60, 70, is abnormal, but it really depends on what your baseline heart rate is.
Okay. And then there's another question about sleepwalking in children, and this person's child is always tired during the day despite going to sleep at an appropriate time.
So sorry, Kathy, what was the question?
So I think the question is about sleepwalking in children.
Mm-hmm.
Like how?
So yeah, if your child is sleepwalking, right, and it's going on frequently, and your child feels tired and they're getting appropriate amount of sleep, you should definitely bring that up with your pediatrician. It sounds like you might need to see a sleep specialist and perhaps do a sleep study. So sleepwalking, if it occurs, once in a blue moon, that could be normal. Some people, if they're sleep deprived, they might sleepwalk. But really, if this is something that's been going on for a while, it should definitely be addressed further and sent for probably to start off with a pediatrician, but might need to see a sleep specialist as well and do a sleep study to make sure that there's not a sleep breathing problem going on, like sleep apnea. So sleep apnea we often see in kids that have these abnormal behaviors during the night that are occurring frequently.
Okay. At what age will night terrors be a concern? And often the pediatrician says that the kids grow out of night terrors.
So we typically see night terrors in toddlers. It's pretty common. Sometimes I do see it even younger in kids that are even like, less than 1, but that's not as common. Typically they are benign and kids do grow out of them. But if they're occurring frequently and there's other symptoms going on like snoring or pauses in breathing, that should definitely be investigated further, right? If these events are occurring many times a night, or if they're occurring frequently, that's something that needs to be evaluated by a sleep specialist, because then there could be something else going on like sleep apnea. But typically kids do grow out of them early on in childhood.
And so just one final question. Is it possible that this person just commented, is it possible that I only need 5 hours of sleep because I go to bed at about 11 and then wake up at 4 a.m. many times completely refreshed?
So I can take this question, Dr. El-Shenawy. I mean, some people, right, are just short sleepers. We know that, right? There's some people that just are lucky and they have this genetic, predisposition to require less sleep. Margaret Thatcher was one of them. Bill Clinton, I think, was also another one that just did fine with like only 5-6 hours of sleep, right? The average amount of sleep.
Albert Einstein was another.
Albert Einstein. Yeah, there's a lot of people that are just lucky. Most of these people, you can see the trend. Most of these people are probably are very successful. So you're probably a very successful guy if you're only sleeping 5 hours and you're doing great. But most adults require around 7 to 9 hours of sleep. But there are, again, people that are just short sleepers and they feel fine. And if they have no other symptoms, that just might be a normal genetic variant. And consider yourself lucky if you're one of them.
Oh, and is it okay? Just one last question.
Sure.
If you have time. Okay. How effective are Fitbits and similar wrist devices for measuring awakenings, sleep phases, etc.? What % of total sleep or number of hours REM and deep sleep are minimum thresholds, or what levels might be considered a problem?
All right, I'll take that. So, because I have a lot of patients who come in with their Fitbit data. And I honestly haven't looked into the validity of Fitbit data, even though I have one too. But what I like about it is that it gives us kind of relative information, meaning when you're looking at your data night to night, you can tell that, wow, I had a lot of more deep sleep this night, or this day I didn't have as much. I can't say the Fitbit measures exactly how much REM you had or how much deep sleep, but I think it's a good marker. And I think you can use it almost as a feedback mechanism where if you see one or two nights that are just horrible and you're wondering why, you should kind of look back at your day and see what you did, what kind of stimulating activities you did, what did you drink, what did you eat, how much exercise did you do or did not do, and then that will help you, determine why you're having some good nights and some bad nights. In terms of the percent. We say that deep sleep, which is called N3 or stage 3 sleep, we try to strive for 20 to 25% of your night being in deep sleep, and then pretty similar amount for REM, about 20 to 25%. So basically half your sleep time should be in deep and REM sleep, and the other half should be in very light or what we call stage 1 and stage 2 sleep. So that's completely normal, because I get that really often when people are sharing the data. So at least you can, look at the relative percentages and night to night. I would say, use it for that as a tool.
Great. Thank you so much.
Sure.
Right, so thank you, Dr. Nee, and thank you, Dr. El-Shenawy, for taking the time to present on this and for answering all our questions. So next week, we will have another Lunch and Learn with the doctor, and the topic will be on arthritis, and it'll be on Friday, February 5th at 12 p.m. noon. You could sign up for this program at ebpl.org/calendar. And thank you for everyone who joined us for today's talk, and take care and stay safe.
Thank you. Stay safe, guys. Bye.
Thank you for joining us for this week's Encore presentation. To join us for live programs or to learn more about the East Brunswick Public Library, visit our website at ebpl.org.